If everyone could please take your seats at the table on the yellow sticker, we will begin. There's so much more time for conversation. I'm very excited for everyone to get back to their tables so we can begin. Yes, here we go. Everyone is making their way back to their table with the yellow sticker so that we can begin our third round of table discussions. And so as everyone is making their way to their seats, it is my pleasure to introduce our facilitator for this next session, Dr. Michael Maguire, who is a resident physician at Christiana Care.
Thank you, Charlie. I actually was anticipating that I was going to have to herd everyone back to their tables, so I'm really appreciative that I don't have to do that. Again, my name is Mike Maguire. I'm a resident at Christiana Care. I'm the chief resident in medicine and pediatrics, and I have 23 days left in residency. Thank you. Not that I'm accounting. Thank you, Dr. Hilder. But I am accounting because I had to really do some reflection on my residency and my medical training in preparation for this table discussion, and how, as a chief, some of my roles changed, and what it looked like to engage leadership above me, and then also become a leader myself as my training progressed. So I think, kind of concluding on the last session, Dr. Mitchell really eloquently quoted General Powell that perpetual optimism is a force multiplier. So as we go into this last session, I really challenge everyone to really embrace appreciative inquiry and come together and start to think about how we can engage and effectively collaborate with leadership in a solution-based way. And we'll hear from all of you soon on the 4 questions that are here. The same rules apply. Honest and open collaborative discussion. Please designate a timekeeper and a reporter and a recorder. The questions that you have in front of you, I think at this point we all know the drill, but what factors of leadership at all levels advance well-being in the clinical learning environment? And as a trainee, I really would like to stress that we should be thinking about all levels in the clinical learning environment and all professionals that go into that. So I look forward to hearing from everyone in half an hour. And I'd just like to close with, I'm very proud of the work that we've already started, and I'm looking forward to hearing what's next. Go. Go. Okay, so we're going to wrap up and bring it back together. I'll try that again. We're going to conclude discussion. Okay. I'm going to bring up tables 2, number 1, 16, 13, 8, 17, 6, and 11, designated by our random number generator. While they're making their way to the stage and podium, I'm going to just read a few comments that we got from the poll lever from our public audience. Okay. So With regards to the question, what factors of leadership at all levels advance well-being in the clinical environment? How can you act as a leader to advance well-being in the clinical learning environment? One of our online audience members said, it takes more than having an open door policy, which is a good start. Leaders must be the ones who are intentional about listening and also ensuring that the work environment is a safe space. This message and the activities to support it must be consistent across all departments and levels. Creativity, learning, and collaboration will significantly improve these types of actions. When discussing how we can effectively engage and collaborate with leadership, there were two comments that really built off each other. Strive to understand how each other view the challenges and opportunities to seek, to find common ground and build upon and improve. And the second, arrive with a plan, present cost-effective solutions that can plausibly be carried out as a start. So I think with that, we'll bring up Dr. Rip, do you want to be our first? And we'll hear what all of our groups have had to say.
Okay, hi everybody. I was representing group number 17, and since we had Dr. Nask at our table, we decided that it's all about accreditation. Accreditation is the key. No, it did come up, but anyhow, we got really, it's a great conversation. I'm not sure we got to answer all four of the questions, but I guess with the first factors of leadership to advance well-being in the clinical learning environment, we spoke about really, first of all, recognizing wellness as a priority, to measure it and put some resources behind it, and to have an appropriate administrative representative based on the size of your, as far as resources and so forth, based on the size of the group for which you're responsible. Understanding that smaller institutions and practice settings may have less they can contribute. And then the leader should also be a model of wellness behaviors, and so kind of practice what they preach. And we spoke a lot about our last speaker demonstrating a lot of those behaviors, which was great to see. So the next question, how can we effectively engage and collaborate with leadership? We also spoke about, show up with solutions, not just problems, that leaders often, they might be engaged, but they want to know how to deal with the issue. And also to gauge the readiness of change for your leader, to try to understand where they are. Maybe they're not ready at all, and that's an important. It's important to know that in terms of engaging them, but to really try to understand where they're at in the process. Engaging at all levels of the institution. We really this was one in which we talked about some systematic culture change, that it really takes a long time to do this and to reach out to everyone, but that to be consistent and pervasive and inclusive. And then how can we synergize and leverage the positive aspects of a learning environment? This was really a tough one, but we were talking about prioritizing wellness perhaps over compensation, and thinking about this for the long haul. That these are not quick changes. So thinking about the return coming in over the long haul, and then also searching for those win-wins. Where are the areas that you can synergize initiatives, sort of changing the model of care, team-based workflows, fixing the electronic health record in a way that may have that improvement in both productivity and other measures that the C-suite is really interested in, as well as well-being, the sort of win-wins. That's what we got. Thanks.
Good afternoon. I'm here as the spokesperson for the wonderful Table 2. For question 1, for what factors of leadership at all levels advance well-being in the clinical learning environment, our table thought that it was really important to create a vision so that you would later be able to sell that vision. But it was important not just to create your vision as a leader. You needed to, if you were truly a leader, you needed to figure out what the team you were leading felt were the deficits and where they wanted to go, and then jointly develop with your team a vision for how you wanted to move forward. We also felt it was very important to be very goal-oriented so that you'd know at each point along your journey whether you were succeeding and celebrate those victories as you accomplish them. In terms of how to effectively engage and collaborate with leadership to create a positive clinical learning environment, we thought it was really important to talk about the return on investment and present data and present that argument in a way so that the leadership at your institution understood that this was an investment they were making that would pay off in dividends at the end. We also thought it was very important to involve the leaders in the projects that we were undertaking, and in fact, things like if you're going to create a leadership course for the middle-level managers at your institution, you wanted to maybe take advantage of inviting the CEO of your institution to come and speak at that leadership course and really engage them in being part of the solution. And then make sure that you show gratitude to the leaders of your organization for when they actually make investments in the well-being of your organization. And you want to be able to start with small pilots, and present positive outcomes. For the next question, we thought that it was in terms of engaging at all levels. We felt that you needed to be your own PR system, so you really needed to sell your successes early and often, and highlight the positives as much as you possibly could when you had wins. And finally, for how to synergize and leverage the positive aspects, we thought it was really important to reach out as broadly as you could. And one of our team members said that they created something called You Asked, We Responded columns in their newsletter, where people could say, this is what we want, and then leadership could say, and look, this is what we did. So that was from the wonderful team too, to whom I am very grateful. Thank you for your team membership.
Good afternoon. I am representing Lucky Team Table 13. So there were a lot of things that have been said already, so I'm going to try and make it specific to and not repeat ourselves. So I think some of the themes that came up is having a finger on the pulse of what's going on in the organization when you are a leader, walking around and going to your providers and to your care team and not asking them to come to you all the time was important. Asking for input and feedback and making sure that that's bi-directional at all times, and collectively defining metrics, committing to them, measuring them, and measuring them over time, and not changing them sort of halfway through. Continuing to encourage suggestions for solutions instead of just collecting complaints. That is an effective way to lead, to have people be part of the solution process with you. So how to collaborate? We talked about humility in both directions. As a leader, to have humility towards those with whom you work, but going to leadership also with humility, understanding that and stating out loud that you have one point of view and then perhaps they have a much larger point of view, but here's a possible solution that could be part of their toolkit in improving the institution. Demonstrating value to leadership in your ask. So understanding what is the larger mission of that leader, and then how does your solution fit into that larger ask? Again, sort of creating the win-win. Sorry, I repeated. And then making sure as a leader that you develop a process for being engaged, not relying on random events, not having to hide in bathrooms when you're the CEO or the CMO, because people only have the opportunity to catch you in the hallway, but instead create spaces for them to find you in other places other than at the urinal. So how to synergize and leverage. So define your system and your scope, and then ask, is it too narrow or is it too broad? And who is missing at the table? Defining definitions together, collectively, co-productively. I think there are a lot of times that in an organization we use words and not everybody understands what you mean by those. So defining them and collectively defining them together. And then making sure to use a systems approach to problem solving, that it is not, here's a solution and we hope that it will solve the problem. Thank you.
Can never see over these things. Hi, I'm Carol Bernstein, representing awesome Table 1 back there in the corner. They're really awesome. So with regard to the first question, components of human-centered leadership, we all spoke, and this is, I think John mentioned it specifically, leading by example, that if you're a leader, you really have to walk the walk as well as talk the talk, and that's very, very important for leadership. That you have to have a willingness to help if somebody's around and needs some assistance, that you should be available to do that, that you have to be aware of being in the trenches. And I think Ron talked before about how he went around on the ground and people were like shocked. I think that's really important. That leaders need to be prepared for the role and engaged in the development of other leaders, and that courageous decision-making was far more important than fear-based decision-making, which is what is happening in a lot of institutions. On the second question, there was a lot of discussion about investing in the frontline leadership, sort of the middle managers. Who are the people that are just above the people that are really in the trenches? We had a little bit of a discussion about who that might be in a different system or in different specialties, but really focusing on helping to develop those people and being leaders, since they were so important specifically, that cultural sensitivity be a part of that discussion, as well as empathy and understanding of the C-suite, and that transparency was extremely important for any of this to work. That even though there were going to be different levels at different points in the organization, that if people communicated clearly and understood what was going on in a transparent way, that would be very important. On the third question, we talked about speaking in the language of each group, knowing their concerns, that this came up specifically with regard to physicians, that they shouldn't be complicit in their own destruction. There was a suggestion that physicians just be told, do not work at home in the charts. So I wanted to mention that, and that we needed to help the leaders with the boards that they reported to. That's something that's been a little bit missing in our discussion, that our CEOs and our C-suite report to boards, and that getting together as a group to make change was important. And regarding the last question, we said that was really impossible. How can you put a square peg in a circle using tweezers? So I don't think that we had a lot to say about that point, and that we hope that will come out of this group. Thank you.
Hello, I'm representing the people at Table 16. I'm not orthopedics, I'm the people at Table 16. So first of all, I'm just going to cover, there's been a lot covered already, so I'm just going to keep it to what I think is different. I tried to do the active listening, but I was so nervous about what I was going to say, I couldn't really active listen very well. So anyway, what factors of leadership advance well-being in the learning environment? First of all, we thought being aware of the issue is very important, and being deliberate about what we say and do, and we should promote systems that facilitate wellness. And then we talked about the fact that people leave supervisors. They don't leave their system, they don't leave the CEO, they leave the supervisor that they're actually working with. And so we thought that local leadership had a significant impact, and so that they should model wellness. Second, how can we effectively engage and collaborate to create a positive learning environment? First of all, we felt that bringing it up was a good start, making sure that people knew about it, and that we could talk about return on investment, particularly patient satisfaction, productivity, and recruitment, and how having this positive learning environment, positive culture really makes a difference as far as those are concerned. And that, let's see, next question, how can we engage at all levels? So we thought that bringing up wellness at every meeting as it being an agenda item would be a good place to start. So we get sort of getting it talked about and people thinking about it. In the group that I work in, we have what's called, what's the pebble in your shoe? And so when you have a pebble, I want to hear about it because then we can start addressing your issues. And we're going to talk about the wellness of the group. And then we need to have a reporting structure for solving problems once they're discovered. And then finally, how can we synergize and leverage the positive aspects? So what we came up with was that we could try to take one particular item and make it to be involved with multiple issues. So particularly we talked about mindfulness. And so if we institute a mindfulness program, how does that affect leadership? How does that affect supervisory people? How does that affect in the learning environment? And how does that actually affect patient care? Because when people are mindful, whether it's our supervisors, whether it's the actual teachers or providers, it creates an environment of listening and quietness, and that helps create a positive environment for all of these things to happen. And that's it.
Hi, I'm Marie Brown, representing Table 6. Thank you. And new ideas that haven't been mentioned already. The factors that we talked about that were important for leadership, really aligning that mission. We often feel like we have one foot in each canoe. Compensation related to well-being was key, and I think Ron brought that up very well. Making sure that you address information asymmetry. Again, that leads to transparency. So often the clinician has a little bit of information and then we act on that or respond to that information. But if the information was a bit less asymmetric, we would probably be all on the same page and we'd be less conflicted when decisions are made that are harder to live with. And empower, the pebble in the shoe, empower with quick wins. Don't let perfection get in the way of the good. Dr. Melinda Ashton wrote that piece in New England Journal, Gross, Getting Rid of Stupid Stuff. There's a lot of quick wins out there that would save probably an hour a day if the compliance HR people all got rid of some of the stupid stuff. How to engage leadership, a lot of what was already mentioned. Speak their talk. If they're not clinicians, we really need to, it's easier for us to understand what an ROI is and to come with solutions and always have the solution be or the issue be, it's not good for patients, because that is always the problem. It's not, I'm not getting to the golf course on time, it's the patients are suffering because we're not taking care of our workforce. And develop and maintain those skills. We don't know how to talk to non-clinicians up the ladder, and we need to develop those skills in our middle management and our local leaders. How to engage at all levels, encouraging the wellness officer position, again, aligning the mission. Appropriate onboarding, a lot was mentioned that we don't do good orientation. And we know that nurses have a nurse residency program that is very effective and has clearly halved the burnout rate or the turnover rate. And the board of directors is key. And they are often the last to know that there's a problem with the workforce. And systems approach, two things. When we are teaching residents, sometimes we're teaching, the differential diagnosis, which is really the opposite of looking at a systems approach. We're thinking of what could go wrong, or we're going to miss the headache that's a subarachnoid hemorrhage. We're not thinking that most headaches are not a subarachnoid hemorrhage. So we're focused and we're taught in residency to think of the exception. And that is the exact opposite when you're looking at a problem from an engineering approach. And so just calling that out and saying, take off your clinician hat and put on your industrial engineering hat. So that's it. Thanks.
So coming down towards the end here, I represent Table 11. We cover both sides of the U.S., coast to coast, and Canada in our thoughts. So a lot has already been said, but a couple of points that came up. We talked a lot about on question one, just a leader, their need for commitment, to develop trust, be fair, direct, be good at conflict negotiations. If we're talking about wellness, one of the things is the selection of leadership, and that you don't just want the leader who has a $10 million grant getting recruited. You want somebody that's human and looking at the human-centered quality of care, that they're willing to be vulnerable in taking on efforts and so forth that they have to do. In terms of the second question, we felt it's important that institutions develop some type of a standardized curriculum that all leaders at all levels need to be exposed to and work towards being successful and working together at that. We talked about the concept of linking emerging goals. So every year, different faculty, leaders, and so forth had to be able to come together, defend what they were trying to accomplish each year. Moving on to ideas that we had on question 3, we talked about the importance of the concept of a human-centered care type of system that people worked within, that had to start right at the board level and work its way down through all levels, and that it had to become a quality metric within the institution, because if it wasn't, it didn't really get followed. In question 4, we talked a lot about getting the right people at the table that was talked about before, being sure that everybody understood that when you didn't do it well, the turnover rate, the expense to the system, the importance of the quadruple aim that gets talked about. And I think that pretty much covers what hadn't been touched on.
Okay, Table 8. We echoed a lot of the themes already brought forward. One of the things we were wanting to bring up that we didn't feel was brought forward was making sure leadership understands that these types of engagements require budget, and not only money budgets, but time, and sometimes decompressing the type of life in the year of a program director is where maybe they could have an extra week of CME and have that funded, or have some extra money to do these things that might really help their perspectives and get them more resources through learning that can help the programs. And maintaining and creating programs should be a goal, and making sure that you're trying to align that with a talent retention system would be a way that you could engineer in some success that would also speak the C-suite language of savings and aligning cost metrics. Making sure that people understand that aligning values, would you send your mother to this place? So I think having some North Stars would be a good way to help align what we're doing. We agreed with doing walking rounds at multiple levels of leadership is important. Also, maybe having rotations where medical students or residents and even emerging leaders attend board meetings of the hospital, or maybe have a rotation for a month where they are integrated with the C-suite and have to learn certain things would be an important advancement, and have them understand what a functioning board of directors for a hospital does. They may have influence where they can recommend people to be on a board, or people they're supervising may come before the board for an ask or for discipline. We think that that's important for them to experience, and maybe the only time they can experience it in learning, where it's at low cost for them but high value. Let's see here. making sure that people accessing self-care is not a gossiped about thing in medical education. I think one of the people deserve some privacy. They're entitled to privacy as a worker to be able to access care, and that's often not guarded or thought about in those respects. And trust me, they'll be required to abide by that if they, out in the real world, when they become an employed doctor for a system or as an employee. So they need to learn that early, and making sure people are aware. You know, the part of the original Hippocratic Oath, maybe it was embodied with keep pure and holy both my life and my art, and that's been translated in 2017. People our trainees are taking the oath, I will attend to my health, well-being, and abilities in order to provide care at the highest standard. So that's part of their professional oath and calling and being a physician. We need to make sure we're supporting that. And we also thought the idea of having some metrics that spoke the C-suite language, where maybe having some registries developed through National Quality Forum or other things they understand, where we tie reimbursement to a hospital system, to if they're integrating things that are protective of the staff and trainees, would be positive. Because right now we're really not doing that. We don't have an understanding of physicians getting injured, physicians in trouble, physicians who need to access different things to continue work. And we our patients deserve that we're looking to this. So that was what we came up with.
So in closing, I think we heard many themes about selecting leaders and engaging leadership to create safe spaces to discuss frequently with all of our stakeholders at every level and part of the profession, to improve transparency and understand each other's priorities. I'd like to yield some of my time if any of the tables that weren't coming up to the podium, if they had anything radically different to say as I kind of close out, you can go to the microphones. This is something that maybe we had missed previously, but to make sure that we come with solutions and create a shared vision and celebrate wins with gratitude. If no one has anything additional to say, if everything that was said at, okay, please, table 10.
Trying to find the balance between everything's been said, but not everyone has said it. But one thing that we talked about that was shared was a suggestion to have all accrediting organizations come up with the same well-being standard and apply it across all disciplines.
That's applause worthy. So I think one of the things in closing that really struck me going back to last night's reflections and Dr. Hilder's story about belonging, and really that story made me reflect on some of our past meetings where we talked about loneliness. For me, like this year, the fourth year of your medicine and pediatrics training is often thought of as an easier ride to attending. It's been really challenging for me because for the first time as chief, I've really had to take on a leadership role. And as the one that often came with hopefully solutions, but often complaints on how to improve our residency program, I was now the one receiving them. I think that I've never felt lonelier or more burned out in all of my training, despite my clinical load being significantly less. I think that one of the things that we should probably embrace within our leadership at every level and amongst each other is that we don't always know what's going on behind the curtain or behind the scenes. For me, this year has been filled with trials and tribulations of my family members, my colleagues, people that I've grown to love, who've had their own personal problems and issues that we've had to deal with within a residency. Luckily, MedPeds combined programs are small, so we get to learn each other so well, but it's still unspeakable when someone comes to you and says that their daughter had a cardiac arrest and now needs a valve transplant. And how do you mitigate that? And as the leader, or as my responsibility as chief, to make sure that we still have a thriving clinical practice while that person's going to be out to take all of their needs. I think we've all been in situations like this where we've had to lean on others and others have had to lean on us. And what makes our profession so great is that usually we get through it. But often when we're doing that, we don't necessarily take a look inside at what toll that takes, because we do it for an altruistic reason. I think that when I was going through all of these questions and listening at the table and both at the podium, one of the things that struck me most is really creating a place that's safe with transparency and understanding each other's priorities, and maybe taking a minute to really determine where our C-suite and other leaders who may be above us in this hierarchy, and flattening it a little bit and just seeing them as fellow clinicians of every practice. In talking to some of the CWOs that are at this meeting already, they said, when I was asking them questions to prepare for this, one of the things that struck me was everyone said, you would never believe the amount of time that goes into engaging everyone in a large academic system to be able to kind of figure out the priorities and the tension points. So I think that by understanding that and creating small wins and really appreciating each other with respect and gratitude, we can start to make a little bit of a difference as we tackle this larger problem. So with that, I think I would like to introduce Steve Singer, who's the Vice President of Education and Outreach of the Accreditation Council for Continuing Medical Education, a few floors below us, to come up for final remarks for this day of great reflection.